Hello and welcome. My name is Elizabeth Wade, and I have shared a short summary of my professional background at the end of these slides. The title of this presentation is Successful Implementation 4, Monitoring and Assessment. This is the relevant financial relationship disclosure for this presentation. This is the learning objective that will be addressed during this presentation. These are the key abbreviations that will be used during this presentation. By the end of this presentation, you should be able to answer the following self-assessment question. A measure that assesses compliance with core processes that, when adhered to consistently, contribute to desired health outcomes is referred to as an blank measure. Is it A, structure, B, process, C, outcome, or D, balancing? When we return to the self-assessment question at the end of the presentation, I will provide the answer and discuss the rationale. Once we've implemented an improvement, now it's time to monitor and assess the impact of that improvement. To do this, we need to make sure that we have metrics for monitoring and assessing the impact, and we can incorporate those metrics into either dashboards or balanced scorecards. Ultimately, we need to determine whether our solution achieved the intended outcome. When talking about measures for patient safety or quality improvement, we'd be remiss not to talk about the Donabedian model. The model was developed by Avidis Donabedian, who was a physician and health services researcher at the University of Michigan. He first developed the original model in 1966. According to the model, information about quality of care can be drawn from three categories: structure, process, and outcomes. We'll talk about each one of these. Structure measures are measures that evaluate the attributes, resources, and capacity of a provider, organization, or system to be able to provide services, support quality care, or achieve an improvement goal. Let's take bariatric surgery services as an example to talk about structure measures. For example, in human resources, does the organization have surgeons with education and training in bariatric care? Taking into account our facilities, do we have an adequate number of operating room suites to accommodate the addition of bariatric procedures to the surgical services that we currently offer? And finally, for equipment, do we have surgical instruments, adequate sized beds with scales, and other equipment needed to care for bariatric patients? My favorite part of structure measures are that they also include our culture, values, and leadership. We all know that culture eats safety for breakfast. An example of a medication safety-related structure measure would be patient safety culture of safety survey results. For example, the AHRQ survey on patient safety. Process measures assess how well an organization or area complies with core processes that, when adhered to consistently, contribute to the desired health outcomes. Process measures are usually based on evidence, and they can be measured in response to a specific intervention that is implemented to reduce errors for a process. Some example of medication safety related process measures are pharmacy interventions. We can measure the number of pharmacy interventions and how often we're intervening and what the types and quality of those pharmacy interventions are. Well, we can look at adherence to safe processes that are implemented, such as, are we barcoding? Are we properly using the drug library in an infusion pump? And finally, we can look at process measures with high-risk failure points. For example, are there any medications administered prior to reviewing allergies? The World Health Organization definition of an outcome measure is a change in the health of an individual, group of people, or population that is attributable to an intervention or series of interventions. Examples of typical outcome measures that we see clinically are mortality, readmissions, patient experience, effectiveness of care and safety of care, and timeliness of care. Outcome measures related to medication safety are interesting. We can't talk about the number of medication errors because there really is not a reliable way to measure the number of errors that actually occur. That's the most obvious outcome, but we know that the accuracy of being able to do this is unreliable. Any metrics that specify the type of patient harm should be reliable, clear, and direct. So because of the lack of reliability on the number of med errors, we need to consider using surrogate patient harm measures. Surrogate patient harm measures might include reversal agent use, such as specific medications like vitamin K, glucagon, flumazenil, naloxone. It might include labs that are triggers for a sign that something has gone wrong. For example, an elevated drug level, PTT ranges that are out of whack, or elevated INR. And finally, there might be other indicators of patient harm that we might look for in the medical record, such as abrupt medication discontinuation, falls while a patient is on a number of sedative medications, lethargy, rash in response to medication use, transfer to a higher level of care, or readmission. It's helpful to have balancing measures when we anticipate unintended consequences as a result of an improvement initiative. We want to make sure we do everything possible to reduce the impact of the initiative and minimize unintended consequences. We want to ask the following: what could go wrong as a result of this change? And for anyone who opposes the change, what are their concerns? What are they worried about? So for example, if we're worried about implementing IV room or sterile compounding workflow technology and that impacting throughput from the sterile compounding room, then maybe a balancing measure would be actually measuring turnaround time. Once you've settled on which structure, process, and/or outcome measures are impacted by the safety improvement, you want to develop associated SMART goals for each of those metrics. That means the goals should be specific, measurable, achievable, relevant, and time-bound. These goals and metrics should be developed upfront as part of the project plan and agreed upon by all of the key stakeholders in the project. For example, in a project that we worked on to implement new opioid-naive and opioid-tolerant order sets to meet the ISMP best practice, we developed some primary metrics, which would be the number of naloxone doses administered within X hours of opioid administration. The goals we might associate with that is to reduce the number of naloxone doses from X to Y by 6 months down the road from the time of the project implementation. Another primary metric example could be the number of times the new order set is used. A goal might be to increase the use of the order set by a certain percentage by a certain date. And finally, some balancing metrics might be the time it takes for a prescriber to enter an opioid order. There could be a concern that restricting the use of these opioids to a new order set might increase the amount of time it takes to order. Once you've decided what metrics and goals you want to put in place, now it's time to think about whether you want to put them on dashboards or scorecards. What's the difference? Well, a dashboard is a real-time monitoring tool that provides a display of key performance indicators and metrics. This reflects the current state and helps to facilitate quick decision-making. On the other hand, executives and managers like to use balanced scorecards to track progress towards strategic objectives over time, with a focus on long-term goals and performance trends. Scorecards are often referred to as balanced because their framework consists of 4 or 5 foundations, each of which contribute to the organization's strategy and vision. KPIs are listed under the foundations to which they contribute or are relevant. More likely than not, a dashboard is likely going to be a key part of your medication safety improvement effort. To use a dashboard, you want to first identify the relevant metrics from your improvement projects that you want to include. These key performance indicators that are commonly tracked on healthcare organization dashboards might include patient wait times, bed occupancy rates, and treatment outcomes. For medication safety, depending on the work that you're doing with your program, if you're working on opioids, you might want to track naloxone administration rates. If you're working on automated dispensing cabinet safety, you may want to look at override rates and barcode on removal or barcode on return. If you're looking at the medication administration process, you may want to look at barcode medication adherence rates. It may also be helpful to look at the top medications that are not being barcoded across the organization. And finally, you may be looking at information on order set usage or clinical decision support acceptance rates, alert override rates, and things of that nature. It all comes down to what improvement efforts you're doing. I always recommend that we keep the metrics and KPIs on a dashboard fresh and actionable. So if you're no longer doing work and a process or improvement effort has stabilized, it's probably time to rotate that KPI off and bring on a new KPI that you're actually working on actively improving. You want to make sure that the data is accurate, so have a way to validate the data before it's presented, and the design of the dashboard is important. Why I said rotating data off is because you can have a dashboard that gets really busy and crazy. That won't serve anyone any good if the audience gets overwhelmed by the data that's displayed. So it needs to be displayed in a manner that's easily interpreted by the intended audience. Here is an example dashboard that shows some medication safety KPIs. And here you can see that they're monitoring barcode medication administration overrides, opioid status for surgical patients, and patients who had an INR greater than 5. You can see that this is limited to a very few number of KPIs. It's easily able to be digested, and we can take a look at this and help inform whether or not our improvement efforts are working. For a balanced scorecard, the organization needs to first begin by defining strategic objectives. This is usually part of the strategic plan for the organization. Typically, these will include foundations such as customer or patient satisfaction, financial objectives, operational objectives, objectives that relate to staff development, human resources, and growth. The organizations that use balanced scorecards will select KPIs that are relevant to and monitored under each foundation. Each KPI needs to contribute to the success of that particular strategic goal or objective. Hopefully, one of the foundations that is on your organization's leadership balance scorecard is patient safety. A lot of times, organizations will include days, number of sentinel events on a KPI or high harm related events. That's something that is often tracked on a balanced scorecard. Hopefully your organization may also take into account some structure measures on your balanced scorecard, such as culture of safety or employee engagement in addition to patient satisfaction. This is a specific example of a balanced scorecard. You can see it provides the specific domains of each of the KPIs on the left-hand side with the specific metrics. Each KPI has a goal that's listed, and then for each goal, it shows based on the time frame in each column whether that number was red, yellow, or green. Basically, whether it met the goal, was right on the goal, or did not meet the goal. And at a quick glance, anyone can look at this scorecard and determine what areas and domains they're doing well in and which areas and domains need more improvement work. It's helpful to have a monitoring and assessment strategy to ensure that what was implemented for med safety improvement did what it was supposed to. The frequency and the process for monitoring the effectiveness will definitely vary based on the extent, scope, and complexity of a change. Not every change that you make is going to require a metric that goes on a dashboard or balanced scorecard, but it is really nice to have those dashboards and metrics for changes that are larger in nature, have high visibility, high impact, and are broad in scope across the organization. You're going to have to determine the frequency and appropriateness of when you want to monitor those metrics and what settings you want to monitor those metrics in, whether it's in a governance committee for medication safety, at staff meetings, on walk rounds, or daily stand-ups. It's important that throughout this process of optimization that you're transparent with staff. So if staff brings up an issue, you want to obtain feedback and act upon it. And whether or not you can implement it, you want to let them know. And specifically, if you cannot implement a specific suggestion, it's important to let them know why you can't. This helps to establish trust. And so it's important during this process to provide updates on the progress and status of any suggestions. A stoplight report is a great way to do this. So kind of going back into listing out the suggestions and showing red, yellow, green status of where those suggestions are. It's also great to use things like a feedback board so people can have visibility to where their suggestions are in the process. Now let's go back to that self-assessment question. A measure that assesses compliance with core processes that, when adhered to, consistently contribute to desired health outcomes is referred to as a or a blank measure. Is it A, structure, B, process, C, outcome, or D, balancing? If you answered B, that is the definition of a process measure. In conclusion, we can select and monitor structure, process, or outcome metrics that measure the effectiveness of our medication safety improvement. We can also look at balancing metrics to look at any unintended consequences. Dashboards and balanced scorecards are also important to utilize in healthcare organizations to help track the progress of key performance indicators. Major metrics for projects that you implement can be helpful to include on these dashboards, and it's important to keep the dashboards up to date and fresh based on the initiatives that you're currently working on. These are the references used to develop this presentation. Thank you very much for your time and participation.